let's move on to the next presentation, I think, with the time.
We were feeling lost without you.
Yeah, but my computer crashed. Yeah, sorry.
Can you see my presentation?
Yes, yes.
Okay. I thank AOS and Alcon for inviting me to be part of this webinar. And I also have a financial disclosure. I've been a part of many of the multi-center studies, and I've received grants for investigator-initiated studies from Alcon. I'll be talking on the role of IOL material and edge design, basically concentrating on Clareon IOL with Autonome delivery system, how it is. Hello. Hello.
I'll just mute Dr. Ravi. I think there's some issue.
Yeah, please mute him if you can.
You can continue, sir.
Yeah. So I divide this talk into three components. So one of it is a talk about the IOL material and the edge design. The second on the delivery system, and the third part of it is going to be the recently concluded multi-centered study on the Clareon Autonome lens. So as we all know, the Clareon Autonome is the newer lens, and any lens we look at the biomaterial, biooptics, and biomechanics. When we look into the new biomaterial, this is going to replace the entire Acrisoft platform. And what is the difference between the Acrisoft and the new biomaterial in this is, it has a new lens material is unsurpassed optical clarity. It has a novel hydrophobic acrylic and advanced manufacturing process. And why we need it, we'll just cover up in the subsequent slides. So when we look into this, it is a hydrophobic acrylate and a methacrylate copolymer. It has a water content. Even though it is a hydrophobic, all these lenses have some water content. The water content of these lenses compared to the Acrisoft lens is little on the higher side. So this was made so that the glistening part of it is much lesser. And the rest of the refractive index, photo protection, and the glass transition temperatures are the same as Acrisoft IQ material. Coming on to the other component which is important with the Clareon is a newer, which is called the precision edge design. So what does this precision edge design do? It is designed to minimize the potential for glare and positive dysphotopsia, which we see in the other categories of lenses. The sharp posterior edge designed to minimize the PCO and associated YAG procedures can be reduced. So when we look into how to explain this, they have done an in vitro studies where the light has been a single wavelength of light at different angles have been projected into the simulated eye, and they have studied what is the light getting that is causing this photopsia and in the simulated situations. In the precision edge design, if you can see, there is no, the light is straight away falling on one particular point, whereas in other edge designs, there are reflections and which causes significant glare in vitro studies. So they did study this in multiple IOLs, and the glare component was almost negligible with the Clareon compared with the other platform of lenses which were available. Then they also looked at the image of the slit lamp, how pristine these lenses are. So if you look into various lenses, it gives you an ultra smooth optic delivery among the lowest level of surface age of these monofocal lenses. Comparing them on the slit lamp examination, you hardly can see the anterior surface and the posterior surface of the Clareon lens, whereas in other lenses, you can easily pick them up. So this again, they have studied and they identified the haze intensity among various lenses, and that has been much lesser with the Clareon lens. So this is something which is important also to look at the surface haze. What is surface haze? There is some kind of a roughening on the surface which is responsible for these reflection of the anterior and the posterior surface. Whereas with the Clareon, this haze is almost negligible. So that makes the lens much, much clearer compared to any other lenses. They also looked at the most important thing is subsurface nano glistening, which is seen in these lenses. And to reduce this nano glistening, so they did in vitro studies where all these lenses they were subjected to 18 days in a balanced oil solution at 90 degrees. And then this is a condition which will induce the glistening, and identified which lenses have the glistening. And they found out the Clareon had Clareon and the wavelengths had a much lesser levels of surface nano glistening in these lenses. And the other important thing which we look at is the optical design of these lenses. So if you look into various platforms, these lenses are biconvex lenses, and we can, in case of Clareon and Axial lens, we can use the entire optic design whereas in case of comparative study, it only the 5 mm of the lens is used for the optical purpose. The rest of it is mainly meant for some other purpose. So this has again helped in giving a much more clear vision in patients in scotopic conditions. So this is again the precision edge also helps in apart from this, it also helps in reducing the glare. Comparing with Axial IQ, the Clareon design is almost similar. So there is no difference between the other components of which are the placement of the haptics and the optic size and the stability of the lens are same. To coming again onto the UV protection, these lenses have the same UV protection what the Axial material offers. And if you look at, they mimic almost like a original crystalline lens and protects the eye from the UV rays. So it says almost 10% of only UV rays is at higher light transmission can get away into the eye. So it protects the eye from the UV rays. Then we have one more important component is called the axial displacement of the lenses. With Clareon, it is comparable to single piece Axial again. The Clareon has less axial displacement compared with any other lenses. What is axial displacement? When there is a compression at the back, when the back size is small, does the lens get any axial displacement? Because that again will affect the effective lens position and this. So when we look into this graph to see the Axial and the Clareon, which are the red and the blue, almost have a negligible axial displacement at various compressions experiments which they have been performed. So this is what they do it when it is uncompressed, the axial displacement was negligible, but when they even compressed at 9 mm, the axial displacement was almost negligible in these lenses. So these are things which are important in the newer platform of Clareon lens. So to summarize, Clareon is a new intraocular lens biomaterial with a new hydrophobic acrylic produced with advanced manufacturing technology. It has unsurpassed clarity with low levels of surface age and nano glistening. And Clareon has a unique design with stable force haptics. So it remains the planar when compressed. Precision edge design minimizes the PCO and YAG rate, and it rapidly unfolds. And Clareon utilizes a familiar aspheric bioptic platform. The full 6 mm of aspheric optic can be used. And precise edge design minimizes the transmission and reflected glare. Going on to the second component of it, which is these lenses are
hold on. Sudhir,
yes.
Yes, I have a question for you. Can you go back to your biomaterial slide? I missed it, and for my own clarification, in what way the Clareon material is different than Axial? That if you have any slide of that.
Yes. When we look into Clareon material with Axial, the water content of the Clareon material is a little higher. When we take Axial, it has a 0.5% of them as water content in the lens, whereas in case of Clareon, it is about 1.5%, and they say that reduces the surface glistening and the glistening component.
But apart from the water content, is there any difference in the biomaterial? So to me, is it? I don't know. I'm asking you, is there any difference apart from the water content in these two lenses, Axial versus Clareon?
I'm not exactly sure that the hydrophobic, the mixture of the acrylate and methacrylate, there is some component change. The exact difference, I'm not sure about it.
No, but I don't know whether there is a change or not. Do you know? You may not know this.
Yeah, it's only they say it is the point. The water content in these lenses is a little higher.
In that case, if it is only the water content, the material is the same, in my opinion. Whenever the water content or philicity changes, it doesn't change the material. It will change the characteristics of the material in a biocompatible manner or otherwise, but the material remains same. But here I understand that the material is also different. I don't know whether it's really different or not. So I thought you would know this. But if you don't know, that's right. Carry
Yeah,
on.
I think that the copolymer has some kind of differences.
But you're not sure. But that's your
not
assumption.
sure.
No,
Yes.
that's okay. Then let's skip that.
Going on to the second component, which is the Autonome overview. So the Autonome is again a preloaded design, and that is the first and only automated disposable preloaded design in the market, driven by innovative carbon dioxide power delivery mechanism. This has the speed lever which can control the way in which you can deliver the lenses, and it can go up to a maximum of 3 mm. And the advantage of it is the speed control. It is you can have it. It has a resistance which can reduce. It is like your accelerator on your car. You can increase and decrease the speed, and so then you can control how the lens gets unfolded when it gets into the anterior chamber. And it also has a depth guard which will help in protecting you at the section at your the entry of the wound. And the nozzle has about 3 mm. That also helps you to deliver the lens comfortably and direct your lens into the bag. I'll just show you how this 3-step preparation is done. It is basically, it has a lock-in mechanism where you fill the viscoelastic first with any of the viscoelastic can be used. It's not only Alcon specified. Then you remove the lockout assembly. When you remove the lockout assembly, then the oxygen is, the carbon dioxide is delivered, and you can get the lens from its initial position to the position where it has to be kept close to the nozzle. So you have to see how the lens folds during this process, and based on this, you have to do a small maneuvers in case the lens is not folded in a proper way. 90% of the time it folds very well, and in certain scenarios where it is not, I'll be showing you the scenarios. And you also can control this comfortably with one hand, and that is one big advantage where you don't require the other hand to control. So you can see the position of your handpiece or IA piece is can be same as you can you're with the Autonome device. So these are the different types in which the IOL can get tugged. It can have a deep tug or a tug looped, or in case if it is not tugged well, it can be looped, open loop, or it's a loop outside, or it is a straight. Whenever there is the folding happens in this way, you need to slightly rotate the device as the lens is coming out, so that it can get directed into the capsular bag easily. Whereas in the first scenario, you need not even rotate the your device. Straight away you can release the lever and you can go ahead with it. So they did a study in almost about 800 eyes, where each of the surgeons were given 6 eyes in a Procine and asked them how comfortable are they. And 68% of them said it's easy to control, and 85% of them had could really feel the resistance and control the speed lever in the way in which they want. So, and 70% of the surgeons rated the overall experience of Autonome as smooth and effortless. So to summarize, it has no, we do not need to use any force or in push. It is an automated procedure where you use your lever to control the speed, and it is single-handed. It enables a precise control of the nozzle to deliver the lens into the capsular bag. So going on to the third part of it is the recently concluded multi-center study. It is a post-market clinical study of the Clareon Autonome with an Indian population. The purpose was to describe the clinical outcome and safety throughout the 1-year post-operative period and IOL delivery performance of Clareon Autonome in clinical use, and to gather data in the clinical experience of Indian surgeons, and also data on clinical effectiveness and safety outcome of using Clareon lens in early phase of post-product launch. The methodology, it is an interventional prospective study, a post-market single-arm unmasked multi-center with 12 months follow-up in an Indian population. So we had about 115 eyes from 115 patients enrolled from 7 different sites, and the study subjects are being followed at appropriate intervals to study various components of the outcomes. So the follow-up period was immediately of the first 2 days, within 1 week, 1 month, 6 months, and 1 year. These were the follow-up steps. Inclusion criteria: we had all patients above the age of 20 years, and only thing we only had the lenses between +15 to +30 implanted in this study. And again, since we didn't have a toric component platform of a Clareon lens, it was only non-toric component. So we have to make sure all the patients had a regular astigmatism of less than 1 diopter. The exclusion criteria included any other pathology which will interfere with the outcomes of the results. So the primary endpoint of this study is to identify the percentage of eyes which achieve monocular best corrected visual acuity of 0.2 logMAR or better at 1 month. The secondary endpoint is monocular best corrected distance visual acuity, uncorrected distance visual acuity at 1 month, and difference between the predicted refraction and the manifest refraction at 1 month post implantation. And they also had exploratory endpoints: surgeon's preference for Autonome device by a questionnaire, assessment of surface haze, assessment of glistening, and percentage of eyes having NDR capsulotomy due to PCO. And as a safety endpoints, which are basically to look at the adverse events. Going on to the results, we had 115 patients enrolled. 111 patients had surgery in only one eye, and 40 patients had surgery in both eyes. And the age, gender, average age was 59 years, and there was no difference between male and female. And looking at the baseline characters, as I said, most of them had an axial length of 21 to 26 that was responsible to have the lenses between 50 and 30. Actually, the Clareon platform comes from the range of 6 to 30, but for this study, we restricted only up to 50. And mean corneal astigmatism was 0.5 to diopters in all these studies. Coming on to the results, 94.7% of eyes postoperatively met the primary endpoint of 0.2 logMAR or better visual acuity at 1 month. So this was the results of the first eye and the results of the second eye. And the secondary effective endpoint, which is a monocular best corrected distance visual acuity, was again 0.008 in the first eye and minus 0.0006 in the second eye. So this again is the median range is minus 0.28 minimum to maximum of 0.8 in these eyes. Coming on to the uncorrected distant visual acuity at 4 months in all the implanted eyes, you can see that was about 0.1 in the first eye and 0.08. So it is less than 0.1 logMAR in all of these eyes. So going back into Snellen's best corrected distance visual acuity of various lenses, they found there's 97.4% of them had vision of 20/25 or better on Snellen's chart. And this is again the distribution of them in the first eye and the second eye. The same thing with uncorrected distance visual acuity, 83% of them had uncorrected distance visual acuity of 20/25. Why this is because of the uncorrected astigmatism in some of the eyes where uncorrected distance visual acuity was little less compared to the best corrected distance visual acuity. And finally, at 1 month, 100% of eyes were within 1 diopter of refractive target. This is the actual difference between the predicted refraction minus the actual spherical equivalent. From the predicted error we calculate, and most of them were within 100% of within 1 diopter of refractive target. Secondary effective endpoint, again, this predictive error was in the range of 0.25 in the first eye to at 1 week. At 1 month, it was 0.25 again. The same with the second eye. So it was the difference between the predictive error and the actual what was seen in these eyes was very much within acceptable limits. They also studied out the preference of the Autonome device by the by various surgeons, and they looked at the current practice, what they were using before, and they compared with how did they found with the new device, the insertion technique and preparation. Most of them felt it was very easy, and the way in which the incision size and they needed to increase the incision size and the delivery control, the speed with which the control, and compared with their previous techniques, most of them felt it's controllable and very controllable, and some of them felt it is much more comparable to the previous device. And hand posture, many of them felt it is more intuitive, and they had much more control with or same as the previous devices which they have used. And finally, the preference and recommendation, they all strongly recommended to, or either recommend or strongly recommend to go ahead with the newer platform. Coming on to the results, because we don't have the long 1 year follow-up results. This were the results of the first 1 month safety. There was no surface haze was reported in any of the lenses. As far as the safety endpoints, there were one case of dehiscence, otherwise no major adverse events were reported in the study. To conclude, the Clareon Autonome is a newer device. The objective of the study was to gather very early clinical experience of Indian surgeons. In 1 month study, at 1 month follow-up, 98% of the first eyes and 94% of the second eyes achieved a preoperative monocular best corrected distance visual acuity of 0.2 logMAR or better. And looking at Autonome, 100% of them, people who have used able to start, stop, or control the speed of delivery during IOL incision. 85.7% found it much easier to prepare the Clareon Autonome than others. And 57.1% found it very easy to insert Autonome into the incision site than others. And 71.5% preferred Clareon Autonome over currently used delivery system. And there was no surface haze was reported for any of the eyes at these, and no major adverse events were reported at this. So we are awaiting the long-term results of 1 year study, as the study was just about concluded and the data lock has been applied. So probably in the next presentations, we will be able to have the results of the 1 year follow-up, which are basically looking at the glistening and the PCO rates. Thank you.
Thank you, Sudhir. Very interesting presentation. Well done.
Thank you, sir.
I just didn't get it. What is the incision size